Excellent. Welcome everybody today. I'm Steve Fisher, your OKA president, and honored today to have two special guests with us, Jessie Farron and Flavia Kilele, who will be joining us today from the WSIB to talk about the new musculoskeletal program of care. We're really excited to have both Jessie and Flavia here with us today. Jessie's the Director of Health Services for WSIB, also an occupational therapist, and Flavia is a chiropractor and program and provider specialist with WSIB. Jessie and Flavia, really excited to have you here to take some time out to share the new program, musculoskeletal program of care with us. For all of the audience that's joining us today, what we would ask is if you can use the Q&A function. If you have questions through the presentation, just enter them into the Q&A. As we get to the end of the session, I'll review those questions with Jessie and Flavia for the benefit of everyone, and then we can move forward that way. So with that, Jessie and Flavia, thank you so much, and really looking forward to the presentation.
Great. Thank you so much, Steve. Thank you so much for everyone who's attending tonight. We know it's the evening, you're probably finishing up your day, so truly appreciate you coming and making time to hear this presentation. We're so excited to announce this new program, and we hope that there's a lot of benefits for you and positive changes to come. I do want to thank the OKA for their collaboration in the development of this program. We were fortunate enough to have Greg Gillum as part of our working group, who provided valuable advice and feedback. So thank you for your contributions and looking forward to future collaboration. So today, what do we want to go over? So our objectives of the session tonight, we want to describe the WCB healthcare continuum and where the musculoskeletal program of care fits within that continuum. We want to look at the key elements of this new program of care, including the admission criteria, the structure of the program, as well as how to deliver the program. We'll talk a lot about the program of care reporting requirements, as well as the communication touch points. And we'll describe the registration process and the implementation timelines for this program. So to start it off, this is WCB's healthcare continuum, so may or may not be familiar to some of you if you've worked with us before. So ultimately, there's three components to our continuum. So our community programs and services are one area. The other two areas are our contracted hospital partners delivering the occupational health assessment program, as well as our specialty programs. So key feature and main point of our continuum is that it's not linear. We really want to make sure that injured people are accessing the right services at the right time that's required for their injury. So we know, unfortunately, some of our injured people suffer very severe injuries. So a severe burn, amputation, occupational disease. And when these injured people enter the continuum, they go right into our specialty program services. So through specialist assessment, interdisciplinary care, we have expedited access to surgery, inpatient treatment. So we know that some enter right at that point. But we know that the majority of injured people who access healthcare through the WSIB, over 80%, go into the community and recover and return to work in the community. So we really want to focus on how we can improve and continue to use these community programs effectively. We also look to our community partners, such as yourself, to help us understand where additional treatment or services would be beneficial. So we know some people start in the community, but they do need something else. So we look to you to help us triage and facilitate that care where it's required. So tonight we'll focus in, obviously, on our community programs and services. So wanted to level set where we are current state. So currently we have three programs of care for physical injuries, the low back, shoulder, and the current musculoskeletal program of care, as well as the non-surgical fracture episode of care. So these are all evidence-based bundled programs and the first line of care for injured people in the community. We have the mild traumatic brain injury program of care, first line of care for concussion in the community. This was recently redeveloped in 2020, probably not recent anymore, but I keep saying that. These last 3 years were quick. But we saw really great success from this. A lot of work to streamline that program, make it easier to use, and obviously the evidence for concussion has changed significantly since the initial program. So we've seen great outcomes from this. We also have the community mental health program. So that's a psychology services delivered by psychologists in the community. And then we have the noise-induced hearing loss program of care. So for a very specific cohort of injured people. Any care that's delivered outside of these programs is delivered through fee-for-service and through that model, but we know the majority of our care and where we want our care to be delivered is through these bundled-based programs. So we know that these physical injury program of care at the top haven't been looked at in a long time. So unlike our MTBI, we haven't reviewed them and revised them. So some are actually over 10 years old. So we know that we need to update them because we're seeing barriers. We're here from you as community providers, and we also know internally there's a lot of struggles to getting our injured people to the right care at the right time. So what do some of these barriers look like? We see delayed access to initial healthcare. So from that date of injury that our injured worker sustains until that initial assessment in a program of care, it's not as fast as we'd like it to be. And we hear from you, our providers, indicating you're trying to get a hold of WSIB for approval. You're trying to understand what program to go into. There's a lot of administration on the front end that's delaying that access. And ultimately, we know the sooner someone gets into care and treatment in the community, the sooner they're going to recover and return to work. So we really wanted to look at that and how we can expedite initial access to care. Moving into the 4 physical injury programs I just described, if you're familiar with them, I'm sure you're as confused as we are internally. They all have different admission criteria, different components, different reporting, different structure. So you might be seeing someone and they're in 2 different programs with completely different parameters. So it gets really complicated. A lot of calls we get from the community is just, what program do I put them in and why are they all different? So we needed to look at how we can streamline and harmonize the program. Where there's additional care required after a program, so this is after the 8-week program of care, you no longer deliver it within that program. You go into fee-for-service. And what does that mean? There's no reporting associated with it. There's no parameters associated with it. You get into the question about what fee should I be able to be paid? So is there a way to incorporate this care within the program? Because we do know some people need a little bit extra when they're finished the program. The fees in our programs are outdated. So if we haven't been looked at or redeveloped in over 10 years, we haven't looked at our fees in over 10 years. And that's not fair. That's not fair to you in the delivery of services that you're providing. We want to make sure that our injured people have ultimate access. And that means as many providers as we can who want to work with us and deliver care. So we need to update our fees. And then finally, our program of care reporting doesn't have a lot of information for our case management teams and internal staff to help them support recovery and return to work. We know that you're getting asked for additional information above and beyond these reports. You're getting calls. There's FAF requests coming in. So how can we incorporate more information within the reports while streamlining the areas that we're not really using? Because the last thing we want to do is make it more administratively burden for you, but we do need that functional abilities information. We do need to know if there's barriers. So we need to look at that reporting and figure out the most streamlined way to get that. So we know these barriers existed. So what was our next step? In 2021, we actually procured a healthcare consultant to review all of our community-based programs and services. And part of this process was engaging community providers for their feedback. And that's where we heard a lot of these points in the barriers that I just chatted about. So ultimately, the recommendations from this consultant review were made to support the program redesign to reduce administration, drive accountability, and improve outcomes. Although these recommendations spanned all of community programs and services, our first step in the first phase of this work was to look at those physical injury programs of care and do a redesign of that. And as I spoke to it in the introductions, we did engage with those associations who primarily deliver these programs of care to form a working group of providers in the community that we can collaborate with on developing these new programs. And we were grateful to have OK as part of that. So here's where we land today in the launch of our new program. So the new musculoskeletal program of care. This program will combine the low back, shoulder, current MSK, and the non-surgical fracture episode of care into one comprehensive and harmonized program. So this new program is going to replace those existing 4 programs. Again, this is a structural change. It was really focused on reducing red tape, reducing administrative burden, and making a streamlined program. We know clinical care for MSK injuries hasn't changed significantly in the past 10 years. So truly just looking at how we can optimize the structure of this program. This will be the mandatory first line of care for all suitable MSK injuries. It's an 8-week program divided into 2 4-week blocks of care. And if you are familiar with our MTBI program of care, we have closely aligned the parameters of this program with that to avoid that confusion that we see current state. Key feature of this program is that block 1 is pre-approved for single areas of injury. So in our low back program of care, this is currently the case. So we have a pre-approval for 1 block. So we wondered, how is this working? We did a deep dive and analysis of that low back program of care, and what we saw was incredible results. We saw that injured people are accessing that program 30% faster than any other program of care because you don't need that approval to get in. You can start treatment when they present to you. We also saw that that program of care consistently provided the best return to work outcomes out of all of our programs of care. So when we see results like that, we wanted to make sure that everyone who's accessing this first line treatment is getting that early access to care. So block 1 is pre-approved for those single areas of injury. Where there's multiple areas of injury, current state, we see multiple programs being provided. This gets really confusing. So different program parameters, as mentioned before, but also different reports coming in, sometimes inconsistent. Sometimes the functional abilities in one doesn't match the other. Sometimes we even have different providers delivering the different programs. So within this new program, where there's treatment of multiple areas that's clinically indicated and allowed by WSIB, this is delivered within this one program, the new musculoskeletal program of care. So a result of that, we'll have one set of report templates. So less administration on your end, but also easier for our case managers to understand what's happening in that claim. And then finally, where additional treatment is approved, no longer going into that fee-for-service world and working outside of the program, treatment will occur within a 4-week supplementary block. So this is a bundled block of care with a report at the end and a bundled fee. So taking away any of that back and forth negotiation, you're dealing with just a 4-week supplementary block if that is approved for additional care. So that's high level overview of the program. So key changes, but I'll let Flavia take over and get into some of the details.
Thanks very much, Jessie. Okay, we'll dive right into the admission criteria details. So there are 3 key elements for this program with respect to the admission criteria. The first being the time frame. So how much time has elapsed since the date of the worker's injury? The second being suitable injuries. How do we define suitable injuries for this program? And the third being the claim status, meaning whether the claim is allowed or pending. Okay, taking a look at the time frame. We've set the time frame for this program for workers who are within 8 weeks from their date of injury, okay? And the goal is for people to access care as soon as possible after their injury. And the majority of people, majority of our injured workers will access this program within that time frame. It's important to note, however, that if it's been more than 8 weeks since the date of injury, this is sort of a soft time frame. Having a discussion, having the healthcare provider call the clinical expert line to confirm the appropriateness of this MSK program of care would be required, okay? So if a worker presents and they are beyond that 8 weeks from the date of the injury, then a call to the clinical expert line to have that discussion is required. And if this level of treatment through this program is appropriate, then this is the program that will be delivered for the worker. So the idea was to ensure that workers still get the right level of care through this kind of program, they're not excluded just simply based on the time frame. With respect to how we define suitable injuries for this program, injured people who have sustained an injury to a muscle, a tendon, a ligament, fascia, intra-articular structure, any combination of these, causing any mild to moderate damage would be suitable for this program. So your sprained strains, your tendinitis, your bursitis, your impingement syndromes, your partial ligament tears that are treated non-operatively, these are the kinds of injuries that can be treated through this program. If the worker has had an injury to a bone that's resulted in a fracture, as long as that fracture is treated non-surgically, then that kind of injury, provided the fracture is no longer casted or immobilized, would be suitable to be treated in this program. So you'll notice that this admission criteria is exactly the same as what it is for our current programs of care and episode of care. There's been no change with respect to that. If workers present with another injury that might preclude them, that's something to consider. There should be no clinical evidence of red flags. When reviewing workers, they should not be hospitalized, and workers may be off work or at work to participate. So work status can be flexible there. Now, we recognize that things are not always so black and white with respect to how, workers might present to your office. And wherever that clinical presentation differs from what is listed here, what we're encouraging is the healthcare provider call the clinical expert line to discuss the appropriateness of the MSK program of care. Okay, this way a fulsome discussion can happen, and perhaps workers that on paper, just reviewing this admission criteria would not be suitable, might be suitable after that discussion. Okay, so a call required if there's any deviation from this particular clinical presentation as listed here. With respect to the claim status, Jessie mentioned one of the most important things of this program is that a provider can deliver care right away to a worker. Okay, so block 1 of this MSK program of care can be completed regardless of the claim status, whether it is pending or allowed. A call to the WSIB is not required to confirm approval. So this helps with that access to care. This enables that early access to care. And we know that the majority of our injured workers, in fact, about 85% or so, access care for a single area of injury. So we know this will have a big impact. What is important to remember, though, is that the healthcare provider call in to get approval for block 2 where they might not yet know if approval is required, okay? And this is helpful and prevents the provider from delivering treatment further on into the program without there being any approval, okay? Now, where there are multiple areas of injury identified, a call to the clinical expert line is required to get that approval to treat multiple areas of injury. Okay, this allows an opportunity for discussion, an opportunity to flag and review some more complex injuries that might be better suited for other programs along our WSIB healthcare continuum. Now, the provider can still initiate treatment within the single area of injury for block 1. And if perchance the provider identifies additional work-related injuries as that block progresses, then they can call the clinical expert line at any time to have that conversation and discuss multiple areas of injury. And if they are granted approval for that, then they are able to bill the increased fee for that block, okay? So as you can see, as we've described here, this new MSK program of care allows a provider to treat multiple areas of injury without the need for multiple programs to be approved. All suitable injuries can be treated through this one program, which brings us to defining how we look at single versus multiple areas of injury for this program. And here is the diagram that we present before you, where you can see that we've subdivided the body into 5 anatomical zones. You have the anterior trunk zone there, identified in green. You've got an upper extremity zone, identified in light blue. You've got a lower extremity zone in teal. And looking towards the back of the body, the posterior of the body, you have a neck and mid-back zone in blue, and you have a lower back and buttock zone identified in yellow. So a single area of injury is defined as any and all injuries to one of these anatomical zones. So if a worker were to present with an injury to the left wrist and an injury to the left elbow, for example, the worker would be considered as having a single zone of injury, specifically the left upper extremity zone. Multiple areas of injury are defined as injuries in more than one anatomical zone. So this is where you have 2 or more single areas of injury, as we've described. So if a worker were to present, for example, with a left knee injury and a low back injury, this worker would be considered as having multiple zones of injury. Taking a look more closely between the mid-back zone and that lower back zone, the blue and the yellow that you see before you there, you see that there is overlap between these 2 zones. And this was considered to allow for thoracolumbar injuries. So if a worker presents with thoracolumbar injuries, then these kinds of injuries can be treated in either one of these zones, not both. Okay, and where you have injuries to the pectoral or shoulder girdle or to the hip or pelvic girdle, then these injuries can be ascribed to either the upper extremity or the lower extremity zone as per the diagram. Okay. Taking a look now at a couple tidbits you need to remember. If a provider is treating minor injuries like minor cuts or minor scrapes or minor bruises, and that treatment is limited to advice or monitoring, then if treatment for these minor injuries happens in addition to the primary area of injury, these minor injuries are not going to be considered as a separate area of injury. Where the provider is delivering the mild traumatic brain injury program of care, treatment of the neck is included within this MTBI program of care. It will not be considered as a single zone of injury within the MSK program of care. Therefore, treatment of the neck happens in either one of these programs, not both. Okay, so some changes to the current state. We've made single injuries a little bit broader in scope to encompass all injuries within one limb or one zone. But to balance that out, we are now looking at bilateral injuries and considering them as multiple zones of injury. Okay. In the past, if a worker presented with, let's say, bilateral shoulder injuries, only one shoulder program of care was granted. In this scenario, with this new program, this would be considered bilateral injury presentation, and multiple zones of injury would be allowed. With respect to the spine, injury to the neck and upper back and injury to the low back are considered as two zones. So it would fulfill the multiple zones of injury criteria. And where providers have received that approval, recall that you have to call the clinical expert to get approval to treat multiple areas of injury. Where providers have received that approval, they are able to bill for the increased fee in the delivery of this program. Multiple programs, again, are not delivered. The slide before you is a graphical representation of our structure, the program structure. And for those of you who are familiar with the MTBI program of care, this will seem very familiar and similar, and that's intentional. So we want to harmonize our community programs, and this structure should also lead to less headaches for our community providers who are delivering them, as it is quite similar to the MTBI program of care. So as a reminder, this program is 8 weeks in duration, and those 8 weeks are subdivided into 2 blocks of care. Wherever a worker presents and, is not suitable, is beyond that time frame, 8 weeks since the date of injury, is presenting with multiple zones of injury, recall that this is where a call to the clinical expert must be made. After that conversation, or if the worker fulfills the admission criteria, they can begin block 1. And block 1 begins with an initial assessment. So after this initial assessment, there's an associated report that is submitted to the WSIB. During the 4 weeks, we expect a minimum of 5 visits to be delivered to the worker. This includes the initial assessment visit, but you must remember that it is expected that the providers delivering this program are treating the worker as often as is necessary to promote recovery and return to work goals. Okay, so once these 4 weeks elapse, at the end of this 4-week block 1, you have a midpoint report that is to be completed after your last treatment session within this block. At this point in time, if the provider does not know whether or not the worker yet has entitlement for this area of injury, now is the time to be calling into the WSIB to ensure that there is entitlement on the claim before proceeding to block 2. And this could be a call to the customer service rep, to the clinical expert, to the case manager on file, or to the nurse consultant. This is a good time also for the provider to consider calling the clinical expert to discuss any lack of progress in functional status, or if there are more than 2 barriers identified while treatment is ongoing, and as reported, should be reported on the midpoint report. We expect providers to do this at any point in time through the program delivery, but at the end of block 1, with the submission of the midpoint report, this is a good time to do that, to make that call. From block 1, the worker can proceed to block 2, provided they have entitlement. This is again 4 weeks of treatment. The minimum number of visits here is set at 4. The 4 weeks conclude after the last date of the treatment session, where a care and outcome summary report is then submitted to the WSIB. 1 week prior to the end of this block 2, if the provider feels that the worker is not making a full recovery and is not going to return to work, then they need to call the clinical expert line to discuss next steps. Going on now to some of the outcome measures that are included in this program. We know that outcome measures are just one tool to assist in understanding the progression of recovery, what the worker's response to treatment has been, what specific improvements in symptoms have there been. The key features we considered in selecting our outcome measures for this program were how easy were they to use, how quickly could they be administered to the worker, and how quickly could the worker complete them, how familiar would community providers be with these outcome measures, and where else were they perhaps being used along our continuum. And we had lots of good discussion with our working group and received lots of advice with respect to these outcome measures. And we've landed on these 5 that you see before you on the table on the slide. So we have the Neck Disability Index to assess injuries affecting the neck. We have the Oswestry Low Back Pain Disability Questionnaire affecting or evaluating injuries that impact the low back. We have the Quick Dash for the evaluation of injuries to the upper limb. We've got the Lower Extremity Functional Scale set to evaluate injuries to the lower limb. And we have a generic MSK, what we're calling a generic MSK outcome measure, which is the World Health Organization Disability Assessment Schedule 2.0, the 12-item version, not the 36-item version. And this particular outcome measure is suitable to administer when a worker presents with multiple areas of injury. And it also gives us some quality of life insights. So it's quite a useful tool. So providers are expected to complete at least one of these outcome measures from the list, but they may opt to complete more than one if they wish, whichever one they choose to complete at the beginning, at the time of the initial assessment. The same outcome measures should be repeated throughout the program where they're required. Okay. I'm going to speak briefly about the evidence-based interventions here. You see these 6 listed before you. You know, there were lots of literature reviews conducted in the development of our original programs of care. And although there has been growth in the body of literature and research with respect to treatment of MSK injuries, these basic evidence-based pillars have not changed. So in collaboration with our working group, we also came to the conclusion that an in-depth literature review was not needed at this point in time. And these are the evidence-based interventions that are required to be delivered in this program. The provider is expected to choose these evidence-based interventions according to their clinical judgment and to the worker's clinical presentation, and tailor them based to their functional recovery needs. Whether as a sole provider or as part of an interdisciplinary team, you must be able to deliver all of these interventions and customize them. Okay. Now, where workers require additional treatment beyond the program of care, right now, what happens is that this treatment is being delivered in a fee-for-service model, as Jesse mentioned, and there's no associated reporting, and it gets a little bit messy in terms of how these extensions are requested and how they're approved. It's a little bit of a disjointed exercise. For this particular program, where further treatment is required, the treatment will be delivered in a supplementary block, which is also 4 weeks in duration. It has also associated bundled fees and an associated templated report. Now, you'll recall, prior to the end of block 2, the provider needed to call the clinical expert line if they felt that the worker was not going to recover and not return to work. Following that discussion, the clinical expert is able to approve a first supplementary block if it is deemed appropriate. This is where you are expected to deliver a minimum of 3 visits. At the end of this treatment block, the supplementary report is the templated report that you would be submitting to the WSIB after the last treatment session. If again, you feel that the worker is not recovered and will not return to work, then 1 week prior to the termination of this supplementary block, you can make a call to the WSIB, but this time the call needs to go to the nurse consultant. Again, 1 week prior to the end of this first supplementary block. And a discussion will occur with the nurse consultant in terms of potential extension of treatment, again, through this program in an additional supplementary block. With respect to reporting, our existing programs of care have 2 templated reports. This program now has 4. The new midpoint report, which I indicated to be submitted at the end of block 1, and the supplementary report for that new supplementary block where the supplementary block is approved. Each of these reports has different categories that require the provider to complete, but a common theme across all these reports is the description of worker updated functional abilities. So there's a dedicated section for these across all the reports. And this is really important to us, WSIB, because it helps inform, the return to work capabilities and help coordinate those sorts of activities. Something to highlight with respect to the key changes in this reporting, one set of reports. So you've got these 4 reports for this program, but it is only one set of reports that is used for this program, whether you are delivering treatment for a single zone of injury or multiple zones of injury. Okay, this should simplify things compared to current state. Another thing I'd like to highlight is that functional ability section that I just mentioned. We did expand it. And we expanded it in such a way that its format is aligned with the functional abilities reporting you would be doing for a functional abilities form for the FAF. The way it's been structured on our templated reports is that it is a separate section. It's a standalone section. So it can function as a tearaway that you can share with the worker, and then the worker can share that with their employer and what other relevant parties. And it also offers the worker an opportunity to judge their own progress, to measure their own progress, and take a look at those functional abilities that are reported and see how far they've come. Another thing I'd like to highlight is that although we've expanded the number of reports, providers are paid for the completion of each report when submitted within the time frame, and that the submission of each report is required to release payment for the corresponding block. So that's important to remember as well. All forms can be submitted through the document upload tool, which is available on our WSIB website. And I think I need to mention, Jesse, that fax is still available, but we really encourage this electronic upload tool on our website. It's very easy to use. And a reminder that electronic billing is required for each of these 4 forms. Okay. I think, Jesse, that's all for me. I'll pass it back to you.
We got a break now. Thanks, Flavius. Yeah, it's so interesting. We were so excited about our upload tool. Not new, but we're like, this is what everyone's going to use for the forms. And we keep getting questions about fax. So it's still available, but hopefully we all transfer over, but it'll take some time. Okay, so wanted to talk a little bit about how return to work is incorporated within this new program. So if you work with us currently, you know that we're a return to work organization. So we want to make sure that occupational rehab is the core focus of any of our programs. So really looking to you as our community partners to really discuss work from the beginning of this program with the injured person. We know that they look to you for guidance and support and education, so it should really be part of the treatment from the beginning. So how we're trying to support this is you'll see it within the templated reports. You'll see those prompts. We'll ask you if you've had a conversation about return to work and how that conversation went. And really the purpose is to ensure this is happening, but also to see if there's anything else beyond recovery barriers that could be impeding return to work, because that's where we come in at WSIB and can help support you. So we know our case managers or nurse consultants can get involved if there's some questions for the employer. If there's anything on that end, we have return to work specialists. So that really helps us understand in the reports what's happening. Is there any issues with return to work that we're able to support you in and support your treatment planning? We know that full recovery is not a requirement for return to work. We know that a lot of injured people go back to work in a graduated way. So what these templates also do with the inclusion of the functional abilities information is allows us to help support that. So instead of saying you have to be able to get back to your full duties to go back to work, we'll be able to see what their current abilities are at that stage and then help to match and work with the employer on our end to make sure that there's a job or duties that are suitable to help them gradually get back to work. So ultimately just wanting everyone to stay at work or promptly return to work because we know it enhances recovery and is part of the rehabilitation process. So here's a chart of communication requirements. Flavia touched on a lot of these when she went through the program structure. And as we go through lots of these slides, we talk about all the communication requirements, but that's one of the biggest things we hear from our providers. We're really confusing. We were just chatting before this presentation. WCB is large. We have a lot of different people and it gets confusing as to who's going to talk to who. So this chart is great. This is going to be on our website as part of these slides, but you have it here for reference too. It's in our resource material, but a quick shot of who to call when. Really for you, your primary contact is the same as it is during current POCs, the clinical expert's primary contact. So if someone's outside of admission criteria, if there's multiple areas of injury, if you need that first supplementary block, the clinical expert's your go-to for that. But wanted to really emphasize here that the WCB nurse consultant, the case manager, is always available if there's delays in recovery, return to work. So if there's any questions, concerns, you want that discussion, they're always available to talk. Also, they're available for any information related to return to work. And if you need employer accommodations or what's available there to help with your treatment planning, then they're the go-to to help out with that. We really do want to support you in your treatment. And we know there's a lot that you might not know. You might not know all the details about their job, about the employer. So that's where we can come in and we encourage those calls to the WSIB, nurse consultant and case manager. So going into the fees for the program. So as noted before, we know that fees are an issue, and part of this program redevelopment, we wanted to bring our fees to a market rate. So you can see here the totals for the 8-week program, single zone of injury at $1,040. We know majority of people will go into this based on the data we have on injury type. And then 8-week program for multiple zones at $1,495. So a lot of principles were considered in the development and analysis to get to these fees. We know, first and foremost, we haven't updated. So of course, CPI and inflation was taken into consideration, but a full environmental and market analysis was done to see what comparators are both publicly and privately. So a lot of that was a lot of considerations went into thinking about these fees. We also know that we're embedding that supplementary treatment. We're embedding the multiple areas of injury. So we considered that in the fees. And also know that we're asking, although functional abilities are always part of assessment and reporting at WCB, because we need to know that information, really formalizing it within this program and putting it in the report template. So fairly compensating for that assessment and reporting was considered also within these fees. Flavia touched on 2 key points that we'll bring out that are different in this fee schedule, but I will highlight them again here. As noted, yes, we do have that additional midpoint report in there, but we are pulling out the payment for all reports. So really focusing on getting quality reports and timely reports. So we recognize this as additional above and beyond fees beyond the treatment blocks. So paying for those reports individually. Also, good news when the minimum visits haven't been met for whatever reason. We know that some people might self-discharge. They might go to a different provider. They might recover and return to work. So you're only using a portion of a block. You haven't hit that minimum visit. Where this happens currently, you go into that fee-for-service world again, and it's that question of how many sessions did you do? How can we compensate? Not in this program. You'll get an automatic reduction in the block fee. So a 50% reduction if you haven't hit the minimum number of visits. So who can deliver the MSK program of care? So no change to current state. This is just a little bit more formalized in how we've approached this, and we'll be documenting in our resources. So all regulated health professionals who have a scope of practice to deliver treatment and rehab to musculoskeletal injuries can deliver this program of care. We are saying that this requires the ability to deliver all of the recommended interventions that were detailed as evidence-based interventions that could be used in this program. We know that this program can be delivered solely by an individual, or often it is delivered by an interdisciplinary team. So either way is fine. Every clinician does need to register, and we'll get into those details. Where there is an interdisciplinary team providing the care, there is one person signing that and being the point of contact to make things easier for our internal staff so they know who to contact. Because we do have a requirement for diagnosis as part of this program, a lot of times this is initial healthcare, and we do need diagnosis to actually adjudicate claims. So because of this, if you are not our WCB primary provider, and how we've defined primary provider is chiropractor, physiotherapist, physician, and nurse practitioner. So those that can diagnose, you need a referral from one of these professions. So we have that diagnosis. If you have that referral, you can deliver this program of care. We just ask that if you notice during the treatment, if anything changes, that you're able to communicate with that referring party for updated diagnosis if required. So in terms of registration, maybe one bad thing about this is we are asking you to re-register for this program, but we promise it's a positive in the end because we're going to have a new directory. So if you are familiar with our programs of care, we've had the same directory for a really long time. We've just added to it and it's really outdated and really confusing. And there's a lot of wrong information there. So ultimately not good for our injured people. So they go to that directory to help find care in their community close to home. And if it's not updated with people who are actually delivering the programs, then it's not helping anybody. So our biggest promise with this program was to have a new directory. So because of that, we do need you to re-register. It also allows us to have a new registration form. We do check to make sure everyone is a regulated health professional. They are a member of a college and you've agreed to all the requirements to deliver the program, which is learning about it, looking at our resources, and then agreeing that we do quality assurance over this program. So those two pieces, we have the registration. Good news is the registration is live and running as of now. So we will provide the link later on in this presentation, but it's all good and you can register. I think I did take a quick peek and I saw some kids on there. So maybe it's already getting out. So that's great news. But we promise if you haven't registered, it is relatively painless. It's an online form and shouldn't take too much of your time. We will provide an email address too on our website because we do want to maintain this directory. So if there's any changes to your practice, additions, or whatever, we'll ask that you email us in the future if you do need to change any of that information. So with that, because everything is live, we're ready for a launch as of Monday. So this new program will launch on April 3rd. So that is this Monday. Recognizing that this is a change in practice from our current POCs. There's a lot of resources to review and we are asking that you re-register. April will be a transition month. So if you currently have someone in a program of care, the existing programs of care, you continue on with that program with that injured person. You're not switching over to the new one. It also gives you a little bit extra time. So if you choose you need to start this new program later on in April, no problem. April, you can deliver both programs. As of May 1st, we're asking that all injured people with suitable injuries have to be delivered through this new MSK program of care. So now that will be the only program available to deliver care for people in the community. I did touch on the switch. The switching piece is just a very hard, we did see that a little bit with our MTBI program when we did this transition. It just gets very complicated administratively. So that's why we keep the people in the existing program if you're in that until you're starting a new program with someone. The one thing we'll flag about this transition is if you are using the upload tool for your reports, because we're carrying two programs or two different ways of delivering at the same time, you'll see in the upload tool, the new MSK program of care is indicated by new. We do have to keep our old forms on there because they're still available for use. And we understand that you're going to have to wrap up, send in that last report. We want them all available on the tool for you. So if you are using the new program, the new forms, you'll just see indicated by new. And just make sure you're checking off that one. And then as noted, everything's up on the website. There are a few additions, a couple of pieces that still need to be edited and put on there, but most of the resources are there and ready for review as well as our registration. So encourage you to go over there and check out everything. We also know that we have time for questions today, but a lot of questions come up once you actually start delivering and you get into these situations and have unique scenarios that we probably haven't thought of yet, but I'm sure we'll find out in the next couple of months. So feel free to email us at any time. This is a direct line to all of us in the team at Health Services, but we're always available. So encourage you to answer or send out any of your questions ongoing. So we will go to questions. I do want to mention that as indicated at the beginning of this presentation, we're looking at a lot of community work at this time. So this is one phase of where we're going in the community, and we wanted to refresh these programs. A lot of people enter these programs and they're highly effective, but we also know a lot of care is being delivered outside of these programs, and that is not a formalized way to deliver. So update on next steps is that we are going to have another program for more complex injuries. So this will be for those post-surgical treatment people. It's going to be for work hardening. It's going to be an interdisciplinary program, but we recognize that community providers, and you've told us, and you are delivering it, there's just not a formalized way to deliver it. And it gets complicated when you're getting approvals from our case management team. So we are looking to launch this program this year. It will be a contracted program. So just so we can understand and make sure that the providers who are delivering it have the expertise, the criteria, the clinic space, the equipment to be able to deliver these effective programs. But looking forward on collaboration on that program as well. So with that, we'll go into some questions and I'll hand it over to Steve to send
Great.
them over to us.
Jesse and Flavia, thank you so much for taking some time to join us today. I think this is excellent information, and thank you for listening. I think always valuable to have the opportunity to provide some feedback, and then it's clear that the WSIB has taken all of this feedback wholeheartedly to update programs so that they work the best for the most, and ultimately get everybody back to work as quickly as possible, or keep them at work if that's possible as well. So again, thank you for that. We have had a series of questions have come up. I'm going to start with one that I think is easy because I think it was answered after the question was asked. But just to clarify, are registered kinesiologists still required to receive a referral from a primary care provider to initiate a program of care?
Yes, that is still the case. And primarily for that diagnosis part.
And for those looking for the detailed notes, that was slide 24. So it came up after the question popped there. In terms of the date of injury, how is the date of injury determined from the perspective of cumulative stress injuries that may slowly increase over time and maybe don't have a specific date of injury?
Yeah, great question. We actually got this question recently, similar situation. So it's really determined in the adjudication. So when our eligibility case managers get the claim, they get the medical, and based on that medical, they'll determine what that date of injury is. So there would be some variance here. Sometimes you'll see it backdated. Sometimes it's the day that they report that. But if the question, probably where you're coming from, is that it does impact the admission timelines, right? So if you are looking at something that's started a while ago, so you have a date of injury that's longer before they've even reported, that will be taken in consideration when you make that call to determine if it's the most appropriate care. But there is some variance there. It could be a little bit backdated from when the first medical was sought from that adjudicator's review, or it could be when it was reported.
Okay, great, thank you. So thinking about the assessment report, does the losing my words on a Wednesday evening here. Does the initial assessment report ask for a diagnosis? And if so, how would kinesiologists fill out that form?
So if you have their it does still ask for diagnosis. So the reporting does ask for diagnosis. If you have that referral with the diagnosis, that's what you would input there. And you can reference, on the form 2, it will ask who the referring party is, and that would be the diagnosing party.
Excellent, thank you. A couple more questions here. And if others in the audience have more questions, please feel free to share and we can continue the conversation. For the block 1, does pre-approval mean that they do not need a claim number? So for example, can a PTA deliver care if a regulated health professional delegates the exercises?
Oh, okay. So I think it's 2 questions, right? Trying to link them to maybe 2 questions.
Probably,
okay.
Sorry, yeah. Maybe I should interpret that as 2 questions.
Perfect. So you need a claim. So when a claim is registered, you'll get a claim number. So it does have to be a registered claim. It's still accountable to, obviously we're accountable to employers and someone has to pay. It just means it doesn't have to be an approved claim. So it could be a pending claim. So still registered. Once you're registered, you get the claim number. We have the documents to indicate that it is a registered claim, but you're not waiting for our approval of the claim. It could be pending because we're waiting for more medical. You can go ahead and treat. And then PTA delivering care if RHP delegates the exercises. So again, that's kind of speaking to the interdisciplinary team, right? So a PTA can't register for this program, but a physiotherapist can register for the program. And if they have support services within their interdisciplinary team, they can all be involved in that care. Excellent.
If a patient doesn't continue to block 2, what report is required to end treatment?
Great question. So anytime someone is discharged, the care and outcome summary can be submitted within that first 8 weeks. So if you're getting to say you're at the end of block 1 and it's going to be a discharge, there's no further treatment required, they're recovered, return to work, then you can send in the care and outcome summary, not the midpoint report, or not both. The only difference is for the supplementary blocks. That supplementary block, if you've done 1 and then you're going to discharge, the supplementary block report can be completed. And Flavia, you can correct me if I'm wrong on that. I get confused with the reporting.
No, you're right. You're right. If block 1 is completed and the worker is discharged after block 1, it's the care and outcome summary. And just like you said, for the supplementary block, it is simply the supplementary block report. There is not a care and outcome summary that needs to be submitted after completion of the supplementary block. It's just the supplementary block report. And when you take a look at these reports, you'll see that the care and outcome summary and the supplementary block report are very, very similar to each other. So they provide us with the same amount of information.
Excellent. Jesse or Flavia, if you don't mind, would it be possible the link to register or re-register, do you have that link handy and could we post it in the chat?
Yeah, I can post it.
And just while they're posting that, again, note to everybody, if this is something you're interested in, do register or I guess re-register for that program. And so just a couple questions. One, confirming the slides will be available, and I think the slides are available through your resources, Jesse and Flavia.
Yes, they will be. So the slides will go on the WSIB website as of next week when all of these education sessions are complete. So they'll be available there. Yeah.
Excellent. And for OKA members, we will also make this video, a video of this webinar available for you. So if you need to take some notes or follow up or catch up on some things and supplement those slides, that will be possible as well. Last question. As long as the worker reports the injury to WSIB, are they pre-approved, or is there other paperwork by the workplace or doctor that's needed for admission before they start the program? So just more clarity around that initiation.
Yeah, so as long as this is testing my case management skills, so as long as it is reported, so there's 3 forms that can be sent in. So it's from the worker, from the employer, and then our first healthcare. So I think it has to be the worker and the employer who report it. And then actually, I think it could just be one. I can get back to you on this one for sure. But as soon as someone reports it, then it's actually registered because it's being reviewed. And then you would have that claim number associated with it while it's pending. And we're waiting for additional medical. So I do think it's the Form 6 from the worker that can initiate it. But I can confirm that one for you. Unless, Flavia, you know.
Yeah, no, I think you are correct. The Form 6 can initiate it. Yeah.
Perfect. Excellent. So that Form 6 initiates the opening of a claim number. Once the claim number is there, regardless of the status of the claim,
that's right,
the program can continue or can begin.
That's right. Yeah.
Excellent.
Or that single area of injury.
Correct. Yes. Great. Any other questions from the audience? Going once, going twice. Seeing none, Jesse and Flavia, thank you so much for carving some time out of your Wednesday evening to share all these updates with us. Looks like a really exciting update or refresh to the program that was, by the sounds of it, a desire for everybody to do. So that's great. And we really appreciate your time today and look forward to any future updates that you might have about program changes that are upcoming, as you mentioned. So we look forward to engaging with you on those and helping you to support them where we are suitably trained to do so.
Fantastic. Thank you much. Thank you so much, everyone. And thank you, Steve, for facilitating this.
Thanks so much, everyone. Really appreciate it. Thank you.
Have a great evening.
Have a good night.
Have a great night.
Bye.
Bye-bye.